We're going to call the Health and Human Service Policy Committee to order. So I want to welcome everyone back to the 2020 Health and Human Service Policy Committee. It's good to see you guys. We have some introductions that we're going to do really quick. So as you guys all noticed, and I know you noticed this, that I have a new CLA, Jasmine Dumiglio. She's been fantastic. She has stepped in and I've been working her, and she has just been doing an excellent job. So I'm really excited to have Jasmine to join us. I would like to congratulate Alyssa Fritz, who was my CLA, who has a new position as the Education Policy and Early Childhood Committee Administrator. You know, it's one of those things when you have someone who's like really, really good and you advocate for them because you know they're good and they deserve to be promoted, but at the same time you're like, damn it, you're right, because you're losing someone so good.
Yeah. That speaks well for you, Madam Chair.
I'd like to introduce our new House Research Analyst, Annie Mott. She's not here? Okay. She will be starting soon? Okay. Well, she will be helping with early childhood issues and DHS licensing issues, along with mensure issues. Before we get started, I would like to acknowledge the loss of Representative Diane Loeffler, who's going to be truly, truly missed. Her wisdom and insight and expertise around the issue that came through this committee was just something that will be definitely missed in this committee. But I also, in the meantime, would like to welcome our new member, Representative Huot. Would you like to just give us a little bit about yourself? Share a little bit?
Madam Chair, I thank you for that kind word, and I am excited to be here with you. I've testified before you a few times. In fact, my first hearing was before you. And so I'm winking at Tony. So I'm excited to be here. Naturally, many of you know my background. I've spent 30 years in EMS before coming to the House, and I'm honored. I don't think I'll even bring half of what Diane brought to this committee, but I'm looking forward to learning from all of you, and it's going to be an exciting time for me. So thank you, Madam Chair, and thank you, members.
Welcome. So a couple of quick housekeeping notes. I want to remind members that the committee rules are included in your folders, and these rules have not been altered from last session, including the 24-hour filing rule for amendments and the 2-hour filing rules for amendments to the amendments. And so we have a quorum. So we have a few minutes that we need to approve. So has anyone reviewed the minutes from March the 27th meeting? Okay, Representative Albright.
Madam Chair, I would move the minutes from the meeting of March 27th, 2019.
All right, thank you, Representative Albright. All in favor, say aye.
Aye.
All opposed? The motion prevails, and the minutes are approved for March the 27th, 2019. Okay. Okay, we need the minutes from September the 11th to be handed out.
Thank you. Oh. So you sit next to Peter.
Oh, yeah.
Peter, you can't do
I'll
it.
give everyone a few minutes to look over the minutes.
No, just don't worry, I'll help you vote.
Yeah, that's what I'm afraid of. Worked well last time.
Yeah.
Okay, once you have, would you like to move the minutes, Representative Freiberg?
Sure, I believe a good portion of that meeting was spent on a bill I'm chief author of, so I will move approval of the minutes of September 11th, 2019.
All right, so Representative Freiberg has moved the September 11, 2019 informational hearing minutes. All in favor, say aye.
Aye.
All opposed? The motion prevails, and the minutes from September 11, 2019 has been approved. So we have a few bills on the agenda. The first two bills on the agenda today were both heard by the committee during the 2019 session. They were recommended to pass and be placed on the general register, but after receiving full discussion and public testimony. So both bills were returned to the committee at the end of session in accordance with House Rule 4.20. The bills do not need any technical amendments according to House research, and the chief authors have not requested any substantive amendments. So we're going to have a pair of procedural votes to move these bills back to the House floor without additional public testimony. We have asked each author to give a brief description of their bill to accompany their motion. The first would be from Representative Morrison. So Representative Morrison has the prenatal substance use reporting requirements that were modified. Representative Morrison, if you'd like to move House File 1892 to...
Madam Chair, I move that House File 1892 be recommended for placement on the general register.
Okay, beautiful. So Representative Morrison moves that House File 1892 be recommended for placement on the general register. Could you explain the bill?
Thank you, Madam Chair, members. So this is a very straightforward bill that exempts providers of prenatal care from being mandatory reporters of women who use substances during their pregnancy. The intent of the bill is to engender trust between patient and provider so that women who have substance use disorder get the prenatal care that they need during their pregnancies.
Thank you.
Was that succinct enough?
That's beautiful. Good job. All in favor, say aye.
Aye.
All opposed? The motion prevails. House File 1892 is recommended for placement on the general register. Thank you. The next bill will be House File 2150. Representative Schomacker.
Thank you, Madam Chair. I move that House File 2150 be recommended for placement on the general register.
So Representative Schomacker moves that House File 2150 be recommended for placement on the general register. Could you give us a short description of the bill?
Yes, thank you, Madam Chair. This bill is the one that allows for prescriptions for ED medication to be issued via telehealth visits. Under current law, most prescriptions are allowed to do that, but there are 6 that haven't been allowed, thanks to some legislation from Senator Marty and Representative Gottwald several years back. But solutions to fix the issues that were originally with that have come forward. Senator Marty is on board with this, and the Board of Pharmacy also supports this language as it is.
All right, well, thank you. So all in favor, say aye. Aye. All opposed? The motion prevails, and House File 2150 is recommended for placement on the general register. Thank you. So our next bill is House File 1741 with Representative Huot. So remember, this bill, I hope that you can remember, at one time was presented by Representative Zerwas, who was the chief author, but with his retirement from the Minnesota House, the bill is now in the possession of his previous second author, who is Representative Huot. The bill is in its current form that received a full discussion last September, and we did take public testimony at that time. With that in mind, we are going to have a vote to move the bill to its next stop. The next stop would be the Committee on Labor. The bill does have a technical amendment from House Research to update the language based on other changes in laws in 2019. So we will vote to make that correction first, once the bill is before the committee, which it is. With that, Representative Huot, would you like to move your bill?
Madam Chair, I would like to move House File 1741 be recommended for referral to the Committee on Labor.
Ms. Carkritz, is she? Yes. Could you please explain the A1 amendment?
Madam Chair, the A1 amendments puts this in the bill form, in the order in the bill that I'd like it to be in for that.
Okay. Okay, is that good enough? Can you be a little bit more thorough?
Madam Chair and members, all the A1 amendment does is this section 3, section 424A.01, subdivision 6 was amended in 2019. So we need to further amend the 2019 supplement rather than the 2018 statutes.
All right, thank you.
Simple words.
So Representative Hewitt, can you move the amendment?
Madam Chair, I'd like to move the A1 amendment.
Thank you. All in favor, say aye.
Aye.
All opposed? The motion prevailed and the amendment is adopted. Representative Hewitt, could you please give us a brief reminder of what this legislation does?
Sure. This bill is, it's a great bill. It basically eliminates the discrimination patients have been having when they've had kidney, when they've been the donor of to a kidney recipient, and they've been discriminated against health insurance or something along that lines. It adds leave for organ donations to existing statute for 40 hours of unpaid leave, bone marrow donations. It basically returns active firefighters after a break in service. And it also does repeal the law allowing paid leave for organ donations for public employees. So it pretty much protects the individuals that are donating to the recipient.
All right, thank you. Is there any further discussion from the committee? Representative Albright?
So, thank you, Madam Chair. Members, you've probably seen some folks wandering the halls today from Minnesota, or Donate Life Minnesota. And I requested kind of a special discretionary opportunity from the chair, and I thank you for that. A dear friend of mine, Scott Morton, and his brother went through a pretty substantial, I'll use it in this term, they swapped out parts for each other, and they were highlighted on the Today Show as a culmination of that. It's a 2-minute video, but I think it'll exemplify the type of heroism that donors go through, but also the compassion that is felt by the recipients. And I just hope that you would take it in the vein that it's received.
Yeah, why don't we watch that now, and then we'll go to a vote.
In high school, they found out I had really high blood pressure, and so that's when we found out that I had kidney disease.
In 1980, Jeff Morton was diagnosed with polycystic kidney disease, the same disease his dad, Carlisle, had been suffering from for years.
Both my dad and I, obviously we were going to need a transplant at some point in time.
In 1998, Carlisle's kidneys had deteriorated, and he was placed on the transplant waiting list. Carlisle's oldest son, Scott, got tested to see if he could be Dad's living donor.
Turned out I was a perfect match for my brother. I was a pretty good match with my dad. And very quickly, my dad said, nope, save your kidney for your brother.
Carlisle received a kidney from a nephew in 1998. Then, by 2018, cysts enlarged Jeff's kidneys to the size of 2 footballs.
Because of the fact that my kidneys were so large, it was really starting to affect my health. It pushed my heart over to one side. My breathing wasn't great. I was just going to start spiraling down quicker from that point.
Last August, doctors at the Mayo Clinic placed Jeff on the National Transplant Waiting List.
I thought since I was a perfect match, I'd be good to go. It turned out I was overweight.
Scott weighed 248 pounds, test results revealing his blood glucose levels were too high to qualify as a donor. Doctors recommended he lose at least 28 pounds before he could be considered again.
And I told my brother that I'm going to give it what I have to lose the weight. I was exercising 6-7 days a week. This was my time to step up, and I really wanted to do this for my brother. My goal was to lose a couple of pounds a week to get down to that, 28 pounds, and I exceeded that goal within 90 days.
On January 17th, doctors deemed Scott medically acceptable to be his brother's living donor.
I called my brother, my mom, my wife, and, told them I was able to donate. After that, I just sat down and cried.
The surgeries took place 12 days later.
It's a great feeling to have that kind of family and love and commitment to help each other out. And that's really what it's all about.
So members, just the follow on that, Scott was in today and he's doing fabulously well. He told me that within 3 days of the surgery, he was having beer and pizza at home. I don't know how that works with his diet.
That's right, yeah.
But his brother is also doing very, very well. And for those in the room that are non-physician, which is most of us, his brother had cysts taken out of his body that accumulated in a total weight of 66 pounds.
Oh, my.
Well, that was a really heartfelt story, so
Yeah.
thank you for sharing
Thank
that
you.
with us. Is there any further discussion? Okay, there being no further discussion, the chair renews her motion that House File 17. Okay, here, Representative Hewitt, I need you to renew your motion.
Ma'am, I'd like to renew my motion that House File 1741 be moved to the Committee on Labor
As amended.
as amended. Thank you.
Thank you. So all in favor, say aye.
Aye.
All opposed? The motion prevails and House File 1741 as amended is recommended for re-referral to the Committee on Labor. Okay, so our next bill
This time.
up is House File 3100, Representative Howard. Okay, the chair moves that House File 3100 be recommended for re-referral to the Health and Human Service Finance Division. Where are we going? State government? We're going to state government finance. We have the bill before the committee. Representative Howard, welcome back.
Yes, thank you, Madam Chair.
Please present your bill.
Thank you, Madam Chair and members of the committee. Right now, Minnesotans with type 1 diabetes are asking questions that for many of us, it's really difficult to comprehend. You know, should I buy groceries or pay for my life-saving medication? What if I take a half dose today? Can I make it to my next paycheck? What's going to happen if I lose my health insurance? Will I also lose my life? This is the reality for thousands of our friends, neighbors, and family members all across our state. And we have the power to do something about this crisis by passing the Alex Smith Insulin Affordability Act. As you know, this committee heard this bill last year, or a version of it, and the House passed it, but it did not become law. And a bipartisan group of legislators since session have worked on this bill, and I believe it's a better, improved bill as a result, taking good ideas from both Democrats in the House and Senate, and Republicans in the House and Senate, that really aim to meet 4 standards that we set out, which is we need a bill that addresses the emergency issue facing Minnesotans that can't afford their insulin. We also need to address the long-term challenges facing Minnesotans and ensure that they have a path to affordable coverage. We need to set a program up quickly because lives are literally on the line. And we need to ensure that pharmaceutical companies contribute to the solution. And so I want to just, in broad strokes, walk through what the bill does and what, in particular, the process looks like for the patients. This bill would ensure that there's a safety net in place so that if a Minnesotan is in the place where they can't afford their insulin that they need to survive, they could go to their pharmacy and they could get an emergency fill that day. It's very important that we have a path for them to do that because, as we've heard from patients, this isn't something they can, if you're a type 1 diabetic, you can't just wait till the next paycheck to clear or the weekend to come. You need your insulin immediately. And so this bill provides a path to get that insulin when you need it. And we're utilizing an existing network and delivery method that works best for patients so that patients can fill their prescription at the pharmacy where they do that normally. Additionally, we want to connect Minnesotans to long-term resources that might be available. So through this bill, once you've gotten your emergency refill, we connect you with a navigator through MNsure so that we can help assess long-term options. If we're able to get someone on existing public programs like Minnesota Care, we want to do that and provide a bridge for long-term coverage, which we do in this bill. And we also codify cost-sharing language to cap copays for those Minnesotans who do have insulin on a health plan that at a rate of $30 or less. And on this point, since last session, we've had multiple health plans in Minnesota step up to the plate and voluntarily for this year cap copays at $25 or less. And we're really grateful they've done that. This would simply cap those costs at $30, something that other states have done on a bipartisan basis, move a bill like this forward, and we think it makes sense here to provide that guaranteed long-term coverage for as many Minnesotans as possible. The only thing I would mention on that is it would be wrong to assume because some insurers have capped their copays at $25 that every Minnesotan has the ability to access those health plans. The largest share of the market actually is federally regulated ERISA health plans. Those plans Minnesota doesn't have an ability to regulate, and we've heard from patients that as soon as the press release came out about the capped copays, they called their insurer to see if they could qualify, but found out they'd still be paying very high out-of-pocket, high-deductible costs. We want to create a path so that everyone has access to affordable insulin, which this bill does. Eligibility. The Minnesotans that are eligible for this program are those most at risk of not affording their insulin. So that is uninsured and underinsured Minnesotans that simply can't afford that crushing high out-of-pocket costs, and that includes Medicare patients. That's an area we did not include Medicare in the bill that we passed last session, but since then I've heard from countless Minnesotans on Medicare that find themselves in this precarious position, and it's an area where if we're creating a safety net for those most in need, we absolutely should include them. The funding of this bill is a combination of public resources and a fee on insulin manufacturers. We would have about $900,000 coming in public funds, largely for setup costs. And what we would ask the insulin manufacturers to do is pay a fee that largely covers the cost of the insulin that they have, of course, raised the price and profited richly. A couple more points before we take questions or have testifiers. We know that we need to set this program up quickly because lives are literally on the line. And to do that, we utilize a contract with a third-party administrator to handle the processing at the pharmacy level. And through those conversations, we know that's something that can be done quickly and builds on what pharmacies currently operate. So it's a structure that works well for patients, works well for the pharmacists, and gets insulin in the hands of people when they need it. Lastly, I just want to call out that it should not be lost on us that had we passed Alec's bill in the last session, it would be the law of the land. And since last session, we know of at least 2 Minnesotans that have lost their life rationing their insulin. Jessamiah David Schur was a 21-year-old from St. Louis Park, died of DKA because he couldn't afford his insulin. We know of another Minnesotan that chooses not to be identified, family that someone lost their life. So this is deadly serious, and we simply cannot lose another Minnesota on our watch. So that's why we're here today and hope to move this bill forward as soon as we possibly can.
Well, thank you so much
Madam
for
Chair.
that thorough explanation of the bill. I see you have 2 authors' amendments.
Yes, Madam Chair.
Yes. So we'll get a motion for each of those, and then you can briefly explain the amendment before we vote. So the chair entertains a motion on the A1-1 authors' amendment.
Madam Chair, I'll move the A1.
Okay, Representative Liebling moves the A1-1 authors' amendment. Representative Howard to the amendments.
The A1-1 is largely a technical amendment to clean up language that puts the bill in a better shape.
All right, thank you. Any questions, comments? Okay. The motion, okay, all in favor of the A1-1 amendment, say aye.
Aye.
All opposed? The motion prevails and the amendment is adopted. The chair will entertain a motion for the A2 authors amendment.
I'll move that, Madam
Okay,
Chair.
Representative Cleveland moves the A2 authors amendment. Representative Howard to the amendment.
Thank you, Madam Chair. The A2 amendment reflects conversations we've had with stakeholders. And on that point, I want to mention there's so much work that's been done on this bill over many, many months, working with pharmacists, doctors, patients, to get this bill in the shape it is today. So this amendment would clarify that the insulin we're talking about is self-administered on an outpatient basis. Reason being, there are some insulins that are utilized in hospitals and delivered intravenously, and that's not the insulin we're talking about here in terms of that would be assessed a fee to participate. So I want to just clarify that. We have added language to be specific about what pharmacies will be reimbursed for their participation in consultation with pharmacists, and added some clarifying language about related to potential options for care that we would provide Minnesotans to receive their affordable insulin.
All right, thank you. Any questions? All right, so all in favor, say aye.
Aye.
All opposed? The motion prevailed and the amendment is adopted. So you've already given us a very thorough information around the bill, and so we're going to go to testifiers. And what I would like for us to do is just go through all the testifiers. I hear that the Senate is also hearing an insulin bill, and so some of our testifiers here may be there testifying, so at some point, we will have them to come up to testify here. Our first testifier, why don't we get Dr. Renee Shirtflow? Okay. Welcome to the committee. Please introduce yourself, your name, and your occupation for the record.
Thank you, Madam Chair. My name is Renee Critchlow. I'm a family physician. I'm on faculty at the University of Minnesota Department of Family Medicine. I practice at Broadway Clinic in Minneapolis.
If you could speak up just a little bit more, that'd be great.
How about that?
It's good.
What about now?
It's perfect.
Perfect. I like perfect. It's good. Okay, Madam Chair and members, my name is Renee Critchlow. I'm a family physician and faculty at the University of Minnesota Department of Family Medicine. I practice at Broadway Clinic in Minneapolis and North Memorial Medical Center in Robbinsdale. I'm currently the president of the Minnesota Academy of Family Physicians. Physicians, like many of you, have had a hard time understanding why the price of insulin has gone up so drastically. While there have been improvements in the product and the delivery methods, the price increase cannot be justified. This is a life-saving therapy that has been in use for decades. And as some of you may know, the original patent was sold for $1 because the person who invented it wanted access for everybody. Those times have changed. Insulin is not an elective drug. If you need insulin and you go without it, you can die. And a lot of patients, as the member had mentioned, in order to cope with the cost of keeping their insulin, are doing things like rationing. Now, for those of you who are not familiar with rationing, basically, if I prescribe someone needs 40 units a day, and they take only 10 units a day, they're only causing harm and prolonging a horrible metabolic process. And if they get to the point where their acid in their blood gets to the point where we get what we call diabetic ketoacidosis, that is a result of improper use of insulin by your body. Type 1 diabetics do not even make insulin. Every one of us in this room who's not type 1, we make our own insulin. I'm doing it right now. But type 1s, there is zero ability for them to make insulin, meaning that if they don't get exogenous insulin that we prescribe to them, the moment they stop using it, their body starts to die. In my practice, I've seen patients who can't afford their insulin do a lot of rationing. There's actually a Facebook group online for type 1 diabetics who share each other's insulin. They ration as a group. My patients that I meet in the hospital are the ones that I admit in DKA. Diabetic ketoacidosis. If you've ever seen anyone in this condition, you understand what a toxic presentation means. It's a patient who, when you look at them, you know that they are hanging on barely to life. They are dehydrated to the point where we sometimes have to put 10 liters of saline into their body in order for them to continue living. Rationing may save them money initially. Average cost of ICU stay is $7,000 to $11,000. So these are people who have financial problems already, and they're getting a bill just to stay alive. The patients that we take care of are doing their best. I have one patient, we were talking about how some people are choosing between rent or choosing between paying their health insurance and getting insulin. We had one patient, she had to choose between getting her insulin and paying for her daughter's casket. It was easier for us to work with the funeral home to reduce the price of the casket than it was for us to get insulin for her. There's been a lot of discussion about how private sector is solving this problem, and that drugs companies have private assistance programs and how the insurers are voluntary capping copays. As a physician, I'm very appreciative of these efforts, but I still see patients who are rationing their insulin and delaying care because of their inability to afford what they need to stay alive. Most clinics don't even have the manpower to participate in some of these programs because they are very complex to use. They are unreliable on how quickly they will provide the needed insulin. And most clinics are not set up to collect, store, and dispense insulin. The copay caps announced by the insurance has been very helpful for many of my patients, but what you need to know is they do not apply to all types of insulin. The variety of medications that we use to treat diabetes is awesome. I both teach and practice full spectrum family medicine. And the idea of explaining to people that there's long acting, there's short acting, there's Novolog, there's regular, there's 70/30, there's NPH, and all of the long actings have different brand names and have different coverage through all the insurances. I may have someone very well controlled on a certain brand name long acting medication. If that is not on the preferred list for their insurance company, that's not going to be under the $30 copay. They'll only provide low pay options for the drug that's on their preferred drug list. It may not be the insulin that works best for that individual patient. And this can be very dangerous for all of our patients. I want to thank you for all the attention you're providing improving insulin affordability. As you have all heard, this is a problem that must be solved before the next Minnesotan dies. However, I also must say that it's important to note that high cost of insulin is just one example of much bigger issue related to pharmaceutical pricing. I have patients who are on many other life-saving drugs that are also unable to afford. Case in point, asthma medications, inhalers. There's two basic types of inhalers. There's the controller inhaler that you take every day, and there's the rescue inhaler that you need to take when you can't breathe. You're in the situation where the controller actually becomes the most important one because it prevents you from getting short of breath. It prevents you from getting hypoxic. It's the thing you take every day. It's also the thing that you probably pay the most for. And if your particular controller is not covered, very often people have to switch to another. And I have found that we have patients that only do best on one type of controller medication. And in the beginning of February is when we started admitting them to the hospital, all the time. I was on hospital service this morning. I appreciate my colleagues covering for me this afternoon. We admit people who their number one reason for coming in respiratory distress and hypoxic is because their controller that worked for them was no longer covered, and they have to pay out of pocket hundreds of dollars. Many of these people are children. Working where I am, we do not have a pediatric intensive care unit. One of the biggest decisions I have to make on a regular basis for a child who comes in with asthma exacerbation, strictly because their parents could not afford the new medication, is whether or not they're going to be staying at our hospital or sent to Children's so they can have an ICU. And there's nothing like looking at a parent who's watching their child who's unable to breathe. Those situations don't have to happen, especially when it's someone who literally, I've had 2 people in the last year who literally were well controlled on the medications they had. 5-year-old doing well for years. The drug company switched to one they can no longer afford, and it didn't work for them, and we admitted them to the hospital. And they're on Medicaid, so we're all paying that bill. Anyway, there's so many different examples. I had tons of members sending me all sorts of stories. They're all the same. People are doing their best. The medications aren't covered, and they're very expensive, and they're risking their lives just to go on another day. I commend the work you're doing. I commend you to work in a strong bipartisan manner in a way to address the bigger issue of the pharmaceutical drug pricing. We hear of more people dying from other conditions because they can't afford their drugs. It's time that we made a change. We have an opportunity to do something really good, and I really appreciate the opportunity to speak with you. Thank you, Madam Chair and members. I'm happy to answer whatever questions you may have.
Thank you, Dr. Sherlock. So we're going to go to the next testifier, which is Nathan Lowy. All right, good morning. Welcome to the committee. Good afternoon. Please introduce yourself for the record and tell us a little bit about why you're here.
Thank you, Madam Chair and members of the committee. My name is Nathan Lowy, and I have been a type 1 diabetic for 30 years. I'm here on behalf of myself and also my son, Jet, who is 9 years old and was diagnosed 3 years ago. I live in Winthrop, which is part of District 18B in the southwest corner of District 18B. And as you had said, some of us were over at the Senate hearing. This issue is so important to me that I'm bouncing around from hearing to hearing, spending hours a day in my car. Just this week alone, across the last 3 days, I've been in my car for a total of about 14 hours commuting back and forth for these Senate hearings. That's how much of an urgency that this issue has to myself, my family, and the almost 500,000 diabetics across the state of Minnesota. I just want to throw out some numbers in relation to the cost of insulin. We all talk about $300 a vial as about what the shelf price is. I want to hit that a little closer to home here today. My insulin annually without insurance costs $14,400. My son's is $13,000. That's a total of over $27,000. If you take somebody who earns an hourly wage, I would have to spend $13.18 of every hour's work that I put in to afford the shelf price of myself and my son's insulin. $13.18. Minimum wage is $10. Breaking that number down a little bit further for myself, I use $40 of insulin per day. How many of us in this room go and get a Starbucks coffee each day? We all complain about how much Starbucks or Caribou coffee is. It's $5, $6, $7 a coffee. I have to use $40 a day to stay alive. Just to stay alive for something that if I was not stricken with type 1 diabetes, I would not have to pay anything for because my pancreas would work properly. If we went, if we go without insulin, we die in a very short amount of time. It's mere hours. We know the story of Alex Smith. We know that it was a matter of a couple days between when he left the pharmacy and when he was found deceased. We count the hours. We don't count the days. We don't count the weeks. We don't count the years. We count the hours. The amount of insulin that we have left in a vial, if that was the last vial we have, we are down to hours. And that amount of hours that we have is not a painless time to go from running out of insulin to death. It's a rapid deterioration of our vital organs. It's a rapid deterioration of our health and well-being, and we slip into a coma in as little as 4 to 6 hours. And then we die. So I urge all members of the committee here to continue to work in a bipartisan effort to get this bill passed and to the House floor for a vote, so where it will hopefully pass as well. So we know as type 1 diabetics that we have a safety net for ourselves and a safety net for our children. Because really, do any of us in this room want to look at a 9-year-old child and say, I don't know if you're going to live until tomorrow? I know I don't. Thank you.
Thank you, Nathan. Annette Gentile? Hi, welcome to the committee. Please introduce yourself for the record and
Thank you,
tell us
Madam
why you're
Chair
here.
and members of the committee. Hi, my name is Annette Gentili, and I have had diabetes for 32 years, type 1 diabetes for 32 years. I
Get closer to the mic.
Oh, sorry. I receive $1,200 per month on my disability. I also have heart disease and have had 4 heart attacks. My insulin costs for myself right now are $946. That leaves me a little less than $300 a month to buy food, rent. I am on Medicare, but it doesn't cover the cost of my insulin. So I'd have to buy an insurance supplement, but I can't afford that with the cost of my disability right now. I'm unable to qualify for any of the big pharma patient assistance programs because they say I make too much money. I can't afford a roof over my head, food, and other necessities and buy insulin at the same time. There are times when I haven't bought food, I haven't bought gas. I would skip buying my heart, depression, and other medicines that I need because I needed to buy insulin. I also have a 17-year-old son, and he needs his mom. Because I can't afford the cost of my insulin, I have rationed and gone into DKA and was hospitalized twice in the last 2 years. And it's not an easy time. I used to be ashamed of the situation, and I didn't tell anyone, not my family or my friends. And I know that there are others who are in the same situation, embarrassed to tell their friends and family that they can't afford their insulin. Instead, they ration it and put their lives at risk. In fact, more than a quarter of the people with type 1 diabetes in the U.S. ration their insulin. With Alex's bill, this wouldn't happen, and we wouldn't lose anyone else in Minnesota. It is not fair that we are putting our lives on the line while Big Pharma is making billions. Time for our elected leaders to put our health and our lives ahead of the pharma companies. Thank you.
Thank you so much, Annette. Okay, can we get Sharon Burton? Sharon? Okay. Dan Edvinson? Address him. All right, welcome to the committee. Please introduce yourself for the record and why you're here today.
Thank you, Madam Chair, members of the committee. My name is Dan Andreessen. I'm with the Minnesota Council of Health Plans, the association that represents Minnesota's 7 nonprofit health plans. Thank you for the opportunity to testify this evening. Thank you, Representative Howard, insulin advocates, and so many others who've been working on this issue for so long to find solutions so Minnesotans can have access to insulin. We share that same goal. The council supports the majority of this bill. However, we do have concerns with the language in Section 3 that was mentioned regarding placing a permanent cap on insulin co-pays at $30 a month. This past year, as was discussed, Minnesota's health plans have independently, voluntarily lowered their co-pays for products in the fully insured market. A number of factors went into how each plan arrived to this decision. One of the biggest factors was just seeing adherence rates and trying to improve those and help folks living with their diabetes to manage their disease. It's completely understandable why advocates would be interested in supporting capping copays. When living with a chronic disease that requires a daily medication, you want to know how much money you're paying throughout the year. Health plans are no different. We like consistency. We want to know what costs will be coming in and how we can keep those costs steady throughout the year. Unfortunately, drug companies regularly increase the price of drugs. A cap on a copay would only work in containing costs if drug companies were in turn to freeze their prices. The three insulin manufacturers that have given little indication that the price of insulin will be lowered, and the past behavior protects the price of insulin will continue to rise. This despite the outcry from the public and the threat of legislation here in Minnesota and nationwide. As health plans, we work to keep premiums low as possible, and one way we do this is through copays, which are designed to help manage the growing drug costs by minimizing impacts on premiums. If insulin copays are mandated to be capped at $30 without any other downward pressure on the price of insulin, and insulin manufacturers continue to raise their rates, health plans will likely have no choice but to shift these costs to premiums. This lets drug companies off the hook. We look forward to working with Representative Howard and others on developing innovative solutions on how we can put some downward pressure on the price of insulin.
All right. Thank you so much, Dan, for your testimony. Is Sharon Lamberton? Hi, welcome to the committee. Please introduce yourself for the record and tell us a little bit about why you're here.
Good afternoon, Madam Chair, members of the committee. My name is Sharon Lamberton. I'm with the Pharmaceutical Research and Manufacturers of America, the Trade Association of Biopharmaceutical Companies 38, 3 of which are insulin manufacturers. I'm very proud of all the research we are doing in the space of diabetes. We have about 170 medicines in the pipeline for diabetes type 1 and 2, and diabetes is near and dear to my heart. My mom suffers from type 2 diabetes. I've watched her lose her eyesight, have cardiovascular disease, lose hands and feet to feeling neuropathy, and it's a terrible disease that no one should have to live with without having access to their appropriate treatments and medicines. I've witnessed an amazing evolution of the treatments over the past 30 years that she's suffered from it. We now have inhalable insulin and a lot of incredible other treatments. But with all these life-saving treatments, it doesn't matter if patients can't access it. Our companies have stepped up in a number of ways. We've stepped up with patient assistance programs that our 3 manufacturers currently offer. In addition to those patient assistance programs, we have Medication Assistant Tool, which is 900 public or private programs. That's one-stop shopping where you can access it as a nurse, as a patient, as a caregiver. You can find access to those programs as well as coupons that we have. But insurance is not working like insurance should. Patients are paying unfair prices and costs are going up. This is because discounts are not being shared with the patient at the point of sale. After discounts, net prices of insulin is reduced by about 70% or more. But again, the patients are not feeling that relief. Long-term insulin costs may cost less than today than in 2000. But again, the costs are going up for patients. And this is what we need to address. And this bill respectfully does not solve for the insurance designs that we are experiencing today. We have 3 concerns with this bill. One is that it's duplicative of the patient assistance programs that are already currently offered. Number 2, it ignores the fact that insurers set prices that consumers actually pay, and a number of insurance companies have already set copays that are $0 to $25 or less, and we'd like to see all plans do that as well. We have serious constitutional concerns as well, takings and other concerns that are listed in my statement. Finally, we have solutions we look forward to working with the committee on. One of those solutions is sharing the savings at the point of sale with the patient, passing down the rebates. We have $527 million of rebates that our manufacturers pay here in the state of Minnesota. We would like to see some of that, a portion of that, go to the patients to help them with their access of their drugs. Number 2, we'd like to see the plans design change. All should have capped copays or no deductible, no co-insurance. And then finally, disease management programs that will help patients know how to take their medications exactly as prescribed, and that those programs could be very helpful. But these policies could have an immediate effect and impact without duplicating programs that already exist. In closing, we appreciate the commitment of this sponsor, incredible work of the committee and the sponsor. Would like to continue our work with you all, but this legislation respectfully does not address the key issues of why patients have high out-of-pocket costs.
All right, thank you so much. is Sharon Durr. Sarah Durr.
Thank you, Madam Chair and members of the committee. My name is Sarah Durr. I am a pharmacist, and I work for the Minnesota Pharmacy Association as the executive director. We really appreciate that you are hearing us today. As many of you know, over 90% of patients in Minnesota diagnosed with diabetes who have been prescribed insulin by their physicians have filled this at the community pharmacy. Many of our community pharmacies are open and accessible 24 hours a day, 7 days a week, and those that are not are usually open until around 10 p.m. Pharmacists provide incredible access to Minnesotans, and pharmacists are the #1 healthcare professional a patient will see each year. Pharmacists provide patients with information, training, and services when they present and fill an insulin prescription each and every day here in Minnesota. We believe that the legislative solution should build on the existing patient assistance infrastructure to the greatest extent possible, and we appreciate that the House has seen this. The supply chain infrastructure should continue with manufacturers developing and making insulin products, physicians and other healthcare providers diagnosing and prescribing insulin, and pharmacists and pharmacies counseling on insulin, filling prescriptions, and being a resource for patients and providers. Finally, I'm happy to take any questions you may have today, but we just appreciate that you have recognized the importance of a pharmacist on the healthcare team. Thank you.
All right, thank you so much. Is there anyone else in the audience who wishes to testify? Hi, welcome to the committee. Please
Hello.
introduce yourself for the record and why you're here today.
Madam Chair and members, my name is Abigail Hansmeyer. I am a type 1 diabetic. I have been diabetic for 24 years. I didn't plan to testify at this hearing today, but something I really need to address is how these pharmaceutical programs do not work. If these assistant programs worked, we would not be here. I also want to point out that the programs offered by insulin manufacturers, they are not set in stone. They can disappear at any time. I have tried multiple times to apply to these programs. I've been denied. I will speak to a time that is really hard for me to speak about, but I have shared the story last session, particularly on Kevin's Law, the bill that Representative Bonner worked on passing. I had 1 vial of insulin in my possession. It fell off of my bathroom counter and broke. It was a Friday evening. I called my physician. I told him that what had happened and that I needed a refill. He wasn't in the office. I left the message with his nurse. She said, "I'm sorry, if you're out of insulin, you're going to need to go to the hospital." Over the next few hours, I spent time trying to access emergency insulin through these patient assistant programs that claim that they are there for emergency purposes. I tried to reach out to people I knew within the diabetes community to see if they had extra insulin for me to use. It got to the point where I fell into respiratory distress. I had to call for an ambulance. I was taken to the hospital. I fell into a coma, and I spent 6 days in the ICU. I will no longer sit here and hear insulin manufacturers tell us that they have a plan to help us, because they have not. Representative Howard's bill outlines a path and an avenue for us to feel that we will have a plan in place, a safety net. And I haven't felt hope for that for 24 years. Please, I need everyone to come to the table. We need a plan. I thank you for your time, and thank you again for everyone for allowing me to speak.
Yes, and thank you. Is there anyone else in the public who would like to testify? welcome to the committee. Please introduce
Madam
yourself for
Chair,
the record.
committee. My name is Maria Isa Perez Hedges. Sorry, I'm running over here from the Senate, but I have been a type 1 diabetic for 16 years since I was a junior in high school. I've seen a vial of insulin cost $30 to change to $300 in a matter of that time. I'm a mother now to a 10-month-old. She is at risk of having type 1 diabetes larger than any other child that isn't born to a diabetic mother. I am worried not only for myself, but for her. If there's no plan of action to help me out, if my insurance fails me, what does my daughter have to look forward with a mother who is trying to survive, who has survived being the college student off of her mother and father's insurance and running to the emergency room so I can get a vial of insulin or hopefully an emergency insulin pen? I've survived that. I want to be surviving healthy with a drug, so to call. No, this is the only cure we have to be able to take care of my daughter and to ensure that, God forbid, that if she ever gets this horrible disease, that she has a safety plan that's there for her too. Thank you.
All right. Thank you so much for testifying. Please come up. Welcome to the committee. Please introduce yourself for the record.
Hi, Madam Chair and the committee. My name is Malia Kamara. I'm 17 years old and I'm a senior in high school. I just want to share what my main concern is, and that's going to be college. So next year I'm going to be heading off to college, and then when I turn 26, I'm going to be aging off my parents' insurance. So what's going to happen when I'm not on their insurance and I have college payments to make? What if I'm standing there using my last bit of insulin and I'm sitting there, I don't have any money to buy more, but my blood sugar is high and I need to use the rest of it? My concern is that I'm not going to have any way of getting that insulin on an emergency. I have been in DKA, which is diabetic ketoacidosis, once, and that was one of the scariest things of my life. And I really do not want to go back to that because I am rationing insulin in college and I do not want to die. I want to have a future. I want to have a family. I want to have kids. And I have goals that I want to reach, check off my bucket list. I want to give back to people, which I will not be able to do if I die because I had to ration my insulin. Thank you.
Thank you so much. All right, is there anyone else who would like to testify before the committee? Hi, welcome to the committee. Please introduce yourself for the record.
Hi, thank you, Madam Chair and Committee. My name is Emma Bonawell. As of Monday, I will have had type 1 diabetes for 8 years.
Speak up, can you come closer to the mic?
Yeah.
Thank
Can
you.
you hear me now? Am I good?
A little bit.
Cool. I'm working on it. This is not something I do often.
I know.
I wanted to speak to being a college student with diabetes. I had to drop out 2 years in because I could not afford 3 college classes and insulin. I could not afford to live on my own away from my parents and continue to live. I support my brother. He's high-functioning autistic. He does his best, but when there's a world built against you, there's not much that you can do. So I'm here for him. Because I know if I'm not here, he wouldn't be here either. Thank you.
Thank you so much for testifying. Okay, do we have anyone else who would like to testify from the public? Okay. Why don't we open up for questions and discussion? Representative Edelson.
Thank you, Madam Chair. I just want to note on the testifiers, it was very interesting to hear the Minnesota Council of Health Plans say that they had some concerns around Section 3, but they wanted the drug companies to have more of a stake. And then we heard from pharma, who came up and said, oh, wait, we want the health plans to also have a stake. So that's very interesting. There was a piece about this in terms of when it starts is on July 1st of 2020. Reading this, I mean, it seems like it's pretty, there's a lot of steps that need to happen. Is that realistically going to be able to happen? And then the other piece is, it was at $30. Was it required $30 for when it's an emergency situation? What if somebody doesn't have that? Maybe I read it wrong.
Okay, Representative Howard.
Thank you, Madam Chair. Thank you, Madam Chair. Representative Edelson. To your first question, we do want to stand this program up as soon as possible. And the bill states that we also don't want to set up a program unless we're confident and we know that it's going to work well for patients. And we feel that we can accomplish that in this bill. We set out to do this by July 1st, 2020. We do have a provision that we could, by action of the governor, get this program running sooner if it's ready. One piece in particular is we are using an expedited contracting process with a third-party administrator who's really a key piece of how we're going to process claims and make sure that we're getting insulin into the hands of Minnesotans. In an earlier version of this bill, that was one of the pieces that could have been a stumbling block to get things up and running in a way that works for patients. But in large part because we're using sort of the existing infrastructure for folks in the pharmacy and this process with the TPA, we are confident that we'll have a program that Minnesotans will be ready to use by July 1st.
Representative Edison.
So will it cost $30 if the person's coming in for the emergency? And then the other thing is what if you, I mean, is there going to be safety points where it's like one person can't go to one pharmacy and then the other pharmacy?
Representative Howard.
Thank you, Madam Chair. Representative Edelson. There is a $30 copay for patients to access the emergency insulin. And this is an area, we're going to have to find common ground between Democrats and Republicans to get this accomplished. Over the summer, there were several meetings and several offers back and forth between Senate Republicans. And, our initial offer said we thought that let's not have any copay. But we've moved to have this $30 copay, which is something that we heard from Senate Republicans. So we do have a $30 copay. And we do hope that that is an affordable piece at this population, because the folks that are below, for example, 200% of federal poverty guidelines, they are likely to be either utilizing or eligible for public assistance where they're getting insulin at a free or reduced rate. The folks that kind of get caught in the middle, or someone like Alec, who had a full-time job as a restaurant manager, made about $40,000 a year, but didn't qualify for those public programs, but still couldn't afford his insulin. So that's a little bit where that $30 copay piece comes from. And then to your question about filling so this is the emergency program. You can access this one time, a 90-day supply in a calendar year. And by utilizing a third-party administrator, we're able to safeguard against, someone going to the Walgreens and then going to the CVS across the street. There's a catch in that system. So you'd be able to access the emergency supply one time in a calendar year.
Representative Edison. Okay.
And then they're connected if after that one time with somebody to help them find affordable insulin, correct?
Representative Howard.
Madam Chair, Representative Edelson, yes. The idea is we want to make sure that safety net exists. That's why in the House bill we have a 90-day supply of insulin to provide the time for someone to connect with the navigator. Let's say you're eligible for Minnesota Care. There might be some filing, getting enrolled. That could take some time. So we want to create enough space so that the safety net exists. And then if there's an option to get somebody onto a longer term, more dependable, affordable care plan, that's what we want to do.
All right, thank you. Representative Robbins.
Thank you, Madam Chair. Sorry. This is kind of awkward. I'm going to move over here. Thank you. I did have a couple questions. First, on the point that Representative Edelson was making, is it your thought that people who access the emergency plan would then go to the long-term plan also outlined in the bill? So like 15 months, is that how you envision it working? Or would people go from the 30-day plan to the public assistance programs if they qualified? And so if you could just elaborate on that.
Okay, Representative Howard.
Madam Chair, good question. So we want to make sure that folks have this emergency option. That's really priority number one. And, you know, on the application where they're going to fill out, one of the pieces will be attesting that they're, you know, facing an emergency situation. But we also want to connect them to those long-term resources. There's nothing that mandates that you go into the long-term program. But if you're going to take that route, we do have some expectations of the patient that they will work with a navigator, fill out an application to assess their eligibility for Minnesota Care, et cetera, those kinds of things. So I think it's unlikely that every person that goes through the emergency program is also going to go through the long-term program. But we want to create that option so that people can have that continuum of care.
Representative Robbins.
Thank you, Madam Chair. And a second question I had was about the contract program. Sorry. So in subdivision 2, you know, in lines 1.118 to 121, you talk about this third-party administrator is going to negotiate, but they're not subject to the requirements under 16C, and then it goes through what they are required to do. If you could just talk about this a little bit, I honestly have some concerns. My understanding is that this is going to be run not through DHS, but through the Department of Administration. And I know DHS had a lot of issues with contract problems. And so how will you ensure that the Department of Administration, which, you know, doesn't have this wheel in their wheelhouse, and now we're already exempting them from the normal contract laws, that's, to me, kind of a red flag. So if you could talk about that.
Yeah.
And also, since one of the things they're going to be exempt from under 16C is the request for proposal, if you could address, you know, do you already have a third-party contractor in mind? Or how is that going to be bid out?
Representative Howard.
Madam Chair, Representative Robbins, a couple things. First, Department of Administration, actually, this is in their wheelhouse. They manage contracts all the time. And so this is something that makes sense. And again, the reason why we're exempting is so that we can stand this program up as soon as we can, because we know lives are on the line, and we think that makes sense to do. And thirdly, you know, this third-party administrator, you know, we're not creating a new infrastructure. That we're asking a third-party administrator to process claims in ways they do traditionally. There isn't a huge lift here in terms of reinventing the wheel, and so we think that bodes well. Did I answer all your questions about?
Representative Robbins.
Thank you, Madam Chair. Just, do you have a third-party administrator already in mind, since it's not going to be put out on request for proposal?
I don't, in my conversations with the Department of Administration, I don't think there is one in mind. I know that they're working and having conversations to try to understand exactly how all this would work, but I don't think there's, from what I've heard, I don't think so.
Okay. Representative Robbins. Okay. Representative Freiberg.
Thank you, Madam Chair. I just wanted to point out that issue related to the third-party administrator was actually discussed in the Government Operations Committee as well. So I was satisfied with the resolution of that.
All right. Thank you. Representative Liebling.
Thank you, Madam Chair. And first of all, I just want to thank the testifiers. I've been working on this bill with Representative Howard for quite a while, and I've heard a lot of stories. And you people that were here today are just, thank you for sharing. I mean, I don't know, this never stops being emotional for me, hearing from the people who come and testify about this. And, you know, and nobody's paying for your gas, and nobody's making it easier for you to come here, and we really appreciate that. I really wanted to ask a question of Mr. Andreessen, if he would come back to the table from the Council of Health Plans. And while he's coming up, I want to say, I know he's new on the job here, so I think you're going to get some trial by fire here a little bit. But, appreciate that you're here.
Just for the record, reintroduce yourself.
Dan Andreessen with the Minnesota Council of Health Plans.
Thank you.
Yeah, thank you, Madam Chair. And he's taking over from Catherine Commit, right? I understand. Is that?
She's still here through the recession, but then eventually, yeah.
Yeah. So, Mr. Andreessen, you made a comment about that you thought that this Section 3 of the bill, which limits cost sharing, that basically tells insurers that they have to keep the copays low for insulin. You made the statement at the end of your comments that lets drug companies off the hook for price increases. And that really struck me because that implies that they're on the hook now. I mean, I'd like you to explain, how does this let them off the hook? I mean, it shelters patients from the increases, but patients are in no position to stop the increases. They either have to pay or die. So how in the world does this provision let drug companies off the hook? Could you explain that? You can feel free to take back the statement if you want to.
Okay, Mr. Andreessen.
Madam Chair, Representative Lieveling, I think what we're trying to say is that, right now you have inputs coming into the system and health plans try to figure out a way to pay for those. And so one way we try to manage those costs is through copays, but also premiums. And that if you hold those copays static, that the inputs are still coming in, the drug companies are still charging their rates, and everything we've seen, over the last 10 years, those rates are going to continue to go up. And if that keeps coming into the system, then premiums will have to do something to offset that cost.
All right, Madam Chair, well, thank you. I mean, you're not explicitly taking it back, but I think you understand my point. I think we all understand that costs have to be paid. However, in this case, well, I think a lot of the companies have discovered or finally acknowledged that it's not in their interest to pass these big costs on to patients, because if somebody ends up in the hospital, as these patients have explained, it costs much more. I mean, I don't understand, frankly, why insurance companies have any copay for insulin, because it's completely to their benefit that people are managing their disease well. I mean, I don't get that really, other than a cost-saving thing, right? Other than they're paying money into the system. So if you want to say, well, if we keep the copays low, obviously we have to have the money in some other place. I get that. But, to say that it lets drug companies off the hook implies that they're on the hook now, and they're certainly not. And the insurance companies are in a much better position to negotiate for lower prices and try to figure that out than the patients are, that's for sure.
Mr. Andreessen?
Madam Chair, Representative Lieveling, I agree with your point that, we're trying to reduce the future costs, and that was when we talked to our membership, what was the reason you did this? That was what they were looking at. They were looking at the costs in the long term, and if we can keep those prices a little bit lower and help people get on their insulin, there's costs in the long run that we can save.
All right. Representative New.
Thank you, Madam Chair. Representative Howard, my question is, so first of all, I mean, we have heard really difficult stories, obviously, and I don't think anyone, I suspect everyone is horrified by some of the experiences, and nobody wants anyone to have to do those things, particularly with the high costs that folks have talked about. I think all of us obviously have taken a real interest in this issue, and we all have concerns in making sure that everyone has access to the insulin that they need. And so I suspect everyone at this table has met with manufacturers and different folks on this. At this point, my understanding is that all three of the manufacturers provide $99 insulin without any eligibility requirements. Is there some concern that there are Minnesotans who will not qualify for that?
Representative Howard.
Madam Chair, Representative New, so we have had conversations with the manufacturers, and they have made some changes to their plans fairly recently, and glad that they're doing so. But our largest hurdle and concern right now with those programs, frankly, overall, is the lack of credibility that those companies have with patients. And we've heard about some of that today. What we've heard from patients is that their experience with manufacturer assistant programs are wildly inconsistent, that they're confusing because all three manufacturers have different programs. We've heard they're difficult to access in terms of finding information about. And so I think we have a big challenge that patients either don't, either have had a terrible experience with these programs and so don't use them. And then the other thing I'd call out is that we've heard from two of the largest health systems in Minnesota that explicitly do not participate in these programs. And what they've told us is the reason why is that they simply don't work well for their patients. And so what we're trying to do in this bill is create a little bit more uniformity, standardization, and guarantees for patients that they'll have a solution that they can count on, a safety net that they can count on.
Okay, Representative New.
Thank you, Madam Chair. Representative Howard, so really, there's no reason to believe at this point that there's anyone who will not have access to the $99 insulin. It sounds like there is mistrust, which is probably well placed. It sounds like there have been concerns with this issue in the past, clearly. But is there? Do we know? You know, I mean, you talk about health plans. Are you saying that the health providers? You talked about two of the larger health providers. Have they worked with these new programs yet?
Representative Howard.
Madam Chair, Representative New.
Or are they electing not to with the new programs?
I don't know that. I can say that the two health systems are Mayo and Essentia, which represent a huge amount of the, for greater Minnesota, for southern Minnesota and northeastern Minnesota. And just back to your, it's not true that everyone has access to these coupon programs that cap things at $99. Specifically, Medicare, folks on Medicare are not allowed and there is a federal law piece that is one of the reasons why, but as we've talked with patients and we heard from somebody today that's on Medicare that has rationed their insulin, that's a huge piece of the population that we address in this bill so that our safety net catches everyone.
Representative New.
Thank you, Madam Chair. So I've personally dealt with the donut hole in Medicare, and it is difficult. But my understanding is that the $99. There's the coupon programs. There's the emergency. I mean, there are several different programs addressing several different issues. My understanding is that the $99 program, literally every Minnesotan qualifies. Is there a reason to believe that not every Minnesotan will qualify for the $99? If so, I think we've got some misinformation going here. And like I said, I've met with all of them. And
yep, Madam Chair, Representative New, as I understand, a lot of those $99 pieces work through a coupon system, and the manufacturers have told us that they cannot provide that to Medicare patients. Now, I'll just make the point, any three of those insulin manufacturers are free to come to this open committee, testify before us, and answer questions. To this point, none of them have done so. But our understanding is the Medicare population is excluded.
thank you, Madam Chair. It sounds like we probably need some clarification on that, because my understanding is that they are 100%, like 100% of Minnesotans qualify for those $99 programs. And so my concern, obviously, is being cautious about how we move forward with this. Obviously, we've seen a lot of examples in the last few years about really poor programs. Well, I shouldn't say that, really good, well-intentioned programs in the state of Minnesota being run very, very poorly. And I have concerns about creating a government program that duplicates what is already happening. And I guess I guess I would be interested in seeing, and I know that there's been discussions in the Senate bill. We'll see where it goes. But because I also understand the concern of particularly those living with diabetes of having these programs now and not having them later, and inconsistency and whatnot. And I know there's been some discussion about codifying what the manufacturers are doing, as well as, in your bill, codifying the caps on insurers. So I guess I would like to see some more information on that moving forward. I think, like I said, we see really poorly run programs, and there's some danger in creating something that duplicates what is already being done. And frankly, more often than not, we see what happens at the state. We just don't do it as well. So.
All right, thank you. I have a question. I would like to bring up Sharon.
Madam Chair, could I just respond to that briefly?
Representative Howe. In the meantime, can Sharon Lamberton come up, please? Okay, go ahead.
So just a few comments. Representative New, you mentioned being cautious. I mean, if there's ever an issue where we need to feel a little wind at our backs, it's this one. I mean, 2 Minnesotans have died since we adjourned and didn't pass this bill. A version of this bill has been before this legislature for more than 2 years. We need to figure this out. And to your second point, we're intentionally utilizing existing infrastructure. We're not creating a new IT system. We are utilizing the infrastructure that's in place to deliver insulin to Minnesotans when they need it. And then thirdly, this notion of that private companies do this better than government. We just heard from Minnesotans that have told us, and we've heard it over and over and over again, that these drug manufacturer programs have failed Minnesotans. If there's ever an example where we can't just put our blind trust in a private entity, it's putting our blind trust in these big 3 insulin manufacturers. And so we need to listen to Minnesotans. Patients need to be first, and guided by their experience directs us that we must move forward and move forward quickly with this bill.
Thank you. So Ms. Lamberton, so we have had individuals come up to testify who've been struggling with diabetes for years and years. If I've seen testifiers after testifier talk about their situation. You testify that you have programs, patient assistance programs, medication assistance programs. There's programs available. I have not heard one patient say that they are a part of a program. They know of a program. I have not heard that. I just heard Representative Newt says that there are really poor programs or program run poorly. So I'm going to make an assumption that maybe there's some poorly run programs that maybe you have that no one knows about. So can you share with us what you're doing to reach the people who can benefit from these programs, and who are the folks who are benefiting from these programs?
Madam Chair, members of the committee, I thank you for your question. So I need to preface that I represent the trade association, so I don't represent the 3 insulin manufacturers specifically, but I do know that their programs have reached thousands of patients that have benefited. I wish we could have heard from some of those great stories today. I have empathy for those that have talked, but I do know that we have some programs that are out there by our 3 manufacturers. We also have the medication assistance tool that combines all the programs. Could they work better? I am sure that they could. I have heard these concerns. I've written them down. I'm taking them back to my organization, to leadership, and also to our membership companies that manufacture the insulin, so that they can hear what's been said today, because I think we can improve on it. A lot of these programs, as mentioned, have just been expanded as of January 1st, which is like a month and a half ago. So I commend the member companies that have done this. I think there's a lot of great assistance that they offer. Could more be done? Absolutely. And I'm going to take this feedback absolutely and see what improvements can be made.
Thank you. I'm just wondering, is there anyone here in the audience that can talk about some of your programs, some of the benefits, and how they're reaching everyday people who are suffering from diabetes?
Madam Chair, I wonder, Ms. Gentile, she said she was on Medicare, is that correct? Can you come up and let us know if you've actually applied for one of these 3 programs that my colleague here is mentioning?
Yes, please reintroduce yourself for the record.
Thank you. This is I'm Annette Gentili. Sorry. No, that's okay. I have tried to qualify for these programs through the insulin manufacturers, and they all tell me that I make too high of income to get to the lower price of the insulin. However, the $99 is still going to be a stretch for me. Making $1,200 a month in Minnesota to try to find, I support my 17-year-old son, so to find housing, to find gas, groceries, my $1,200 is almost gone with that, just housing alone.
Representative Edison.
So let me just make this clear. So you make $1,200 a month, and that is too much to qualify for the $99.
And I went to my county. I've went to as many people as I know. I live in Carver County, and I've went to Carver County and asked for help. I do not get any help at all for food stamps. I don't get any help because I make $33 over the income limit is what they told me.
That's really disheartening.
So with insulin being as high as it is, when I started on insulin in 1988, it was $12 a bottle, a vial, $12. Now, my one vial is $646, and the other one is like $3 something, four something. So it's close to $940 a month. So for me to buy that, I don't have any money left. And if you can find rent in Minnesota for less than $300 a month, that would just cover my rent. That wouldn't cover food, other necessities that I need. I have, like I said before, I've had 4 heart attacks. So I have not taken my heart medicine. I don't take it because I can't afford it.
All right, thank you so much, Ms. Gentili. Representative Morrison.
Thank you, Madam Chair. Representative Howard, I just wanted to thank you and commend you for your hard work and perseverance over all this time, and to the testifiers as well. I've seen many of you at different town halls, at testifying at different committee hearings. You have dedicated yourselves to advocating for yourselves and your families and for other Minnesotans, and I want to thank you for that. I also just wanted to, I think there are some misconceptions about diabetes that I just want to clear up. I think, if you are in a position of needing emergency insulin, this is not your first rodeo. You have the diagnosis of diabetes, and you've been struggling with that probably for a long time. People who have diabetes and require insulin are incredibly savvy and smart. They know so much about their blood sugar, how much insulin to take, how to kind of get through each day. And there were a couple of sort of insinuations that, well, then let's get these people into better care. And then, they kind of don't know how to manage their own insulin. More often than not, the issue is that they can't afford the insulin that they need. They know how to use their insulin. So I just wanted to clear that up. And I also had one question. I'm wondering if the coupon programs count towards people's deductibles and their insurance.
Is that Representative Howard?
Do you know the answer to that, Representative Howard?
Or should we bring back
Madam Chair, Representative Morrison, I'm wondering if
Sharon
someone with the
Lamberti?
health plans would know if, I believe so,
Edwards?
for the for the coupon programs?
Well, we're going to have Dr. White
Okay.
come up. Hi, welcome to the committee, and please introduce yourself for the record.
Madam Chair, members of the committee, I'm Cody Weiberg. I'm the Executive Director of the Minnesota Board of Pharmacy. I can't say for these particular programs. However, my oldest daughter happens to be a pharmacist practicing in the community setting. I just called her yesterday to ask about these coupon programs and how they work. Many of them are set up so that there's a coordination of benefit that occurs, if they're copay coupons at least. So what will happen is the pharmacy will bill the primary insurance first, and then will bill the third-party administrator, claims adjudicator that is working for the pharmaceutical manufacturer, and then we'll get a response back for how much of that copay is going to be covered. So that's the way it works for a lot of pharmaceutical coupon programs, but I have not looked into these three in particular, these three companies.
All right, thank you so much. Okay, Representative Keel. Thank you.
Thank you, Madam Chair. I've been wrestling with listening to all of this, and, we talk about who can access it, how difficult it is, and of course, I understand through the Minnesota Department of Health that insulin-related emergency cases, if often are people that they see on MA or MNsure. So I'm going a different direction, and I happen to know a few people that don't deal with their insulin very well. Some are elderly. They're, like you said, Representative Morrison, there are those people who know exactly what they need, when they need it, how much they need. But there are those who are just not handling it well. And I don't think it's our job to necessarily manage that, but I wonder how we handle that when people are not managing their insulin very well, and then watching those people not treat it like it should be, and either get very sick or lose their lives, or however we manage it. But I'm really wrestling with the conversation here, and I won't go into it. I'll spare you the stories, but I have a 10-year-old niece that went into, ketoacidosis, DKA, there we go, thank you, and survived, but at 19 died from it. So I'm personally aware of how dangerous this can be, but there's a lot of different situations about how we get to that point. And how do we make sure that people can access the insulin that they may already have access to? Maybe we should be making sure there are programs that are clear in hospitals, clear in drugstores, so that people know how to apply. Maybe this is a better time to work with our manufacturers and our pharmacists about how we can direct things a little more clearly rather than making a state mandate program. I haven't worked on this certainly as long as you have, but and I really appreciate all the stories and all the challenges. It can be really scary, and I get that. But I don't know if you have anything to offer about, all of the people that are already receiving insulin on MA or MNsure, or MNcare, excuse me, how they deal, how many more people are there that are not in that program that would not be served?
Representative Howard.
Madam Chair, Representative Keel, first, I would hearken to what Representative Morrison said, that most Minnesotans that have type 1 diabetes are very savvy, and how they manage their care is through coordination with their doctor, and that relationship is incredibly important. But this bill is addressing folks that might find themselves in DKA simply because they cannot afford their insulin. And we've heard that that's a problem we're solving for because we know it exists. Other folks, that have access to low-cost insulin, they also might, find themselves in a difficult situation. But we, as a state, shouldn't shouldn't allow for a situation where we have Minnesotans who are maybe showing up in an emergency room simply because they can't afford their insulin. And you mentioned hospitals. I would just call out why this is also a cost-effective solution is we want to prevent people from going into DKA and showing up in a hospital. The emergency room is not a solution to the emergency crisis facing Minnesotans that can't afford their insulin. So what we can solve for in this bill is a safety net for people that are rationing because they can't afford their insulin. And admittedly, there's larger issues at play with making sure Minnesotans have the care they need. But that shouldn't deter us from solving the issue in front of us, which is that Minnesotans can't afford their insulin.
Okay. Ma'am, I think, yes, are you going to respond to Representative Morrison question about deductibles or?
No,
Representative Keel. Okay.
I'm sorry.
Well, please introduce yourself and tell us why you're here. And
Hi, my name is Leah Greenside. I live in St. Paul. My daughter has type 1 diabetes. There's a lot of things I'd like to say, but I will specifically answer the question about the $99 program through Novo Nordisk, which we talked to lobbyists from them this morning, and they confirmed what is also on their website, which is that it does not count to your deductible. I'm not certain about the other companies' programs and all the different variations, but that one for sure does not. One thing to note is oftentimes people use two different types of insulins that come from different companies, so they would then be required to pay potentially $99 for this one and $99 for this one. You all seem to be struggling with trying to understand these programs. I will tell you, after 7 years of managing this disease for my daughter, the programs are extremely complicated, and I think they are done so by design. They change all the time. You're qualified sometime, you pick up your prescription at the pharmacy, it costs you this. You go back the next month, something has changed, it costs you something different, which then sparks multiple phone calls to companies and to your back to your doctor to try to get things written the right way so you can qualify for something new. The programs today are likely a whole lot stronger. I like to think part of that is due to people like me who have been coming here and talking about this and tweeting about it, and the companies are trying to respond, and I do really appreciate that the programs are better than they were even a year ago. But those are, you can read the fine print. They say they can discontinue them or change them at any time, and given past behavior, I am sure that that will happen. So, I feel very strongly that we need to, this is what our government does, right? You step up, we elect you to represent us, to step up to make sure that we're protected from companies I'm not going to blame them. They're supposed to make as much money as they can, and they are continuing to try to do that. But it's on us. We are the ones who are suffering for that. So, that's why I ask you for your support. We need to have a safety net program in place. We need to ensure that the copay caps that voluntarily Minnesota insurers adopted are in law and apply to all insulins. Right now, I have a program. I get my insurance through MNsure, individual plan. I should have $25 insulin through that program. I do not, because my daughter uses not Novolog, the one that's on the formulary, but Humalog. So I know Humalog works better for my daughter. We're talking about how difficult it is to manage. Humalog works best for her. I have to make that really tough decision as a parent. Do I switch her to one that's more affordable, or do I figure out how to try to pay for the one that works best for her and what her doctor has said? You can change that. You can put that into law and say all of the insulins on the formulary should be covered, whatever works best for the patient, not whatever the insurance company decides. So that's what I'm asking you. I think that's what all of us advocates are asking you is please stand with us. This disease is so difficult to manage. As parents, we're up multiple times a night correcting our kids' blood sugars or giving them sugar to bring their blood sugar back up. This would make our lives just a little bit easier and have some assurance that this is not going to be such a struggle. So sorry, that was way.
No, but thank you for bringing some reasoning, some clarity around the questions that we're going to be grappling with.
Yeah.
Right, and how do we really support access? affordable access.
Yeah,
to
and
insulin.
thank you, Madam
So,
Chair.
thank you.
Just one last comment, which is that there are lots of investments into trying to improve diabetes outcomes. It's a really important measure of health of a state, a public health measure. But one of the simplest things that we could do as a state is make sure that people are not struggling to get insulin. I mean, that's going to be much easier than trying to improve, all the other things we do from a public health perspective to improve diabetes outcomes. That alone will help improve those outcomes greatly. Think of it as an investment in public health, if nothing else.
Thank you so much. I think we have Nathan Lowy. Introduce yourself again for the record.
Thank you, Madam Chair. My name is Nathan Lowy. I'll make this brief. The one response that I wanted to make to, I believe, Representative New had a question about the $99 programs and whether we qualify or don't qualify. I don't have the exact answers to that, but I just want to make a point that we are talking about an emergency program, not something that would be ongoing. $99 insulin is wonderful. If you can afford that, that's wonderful. But we're talking about somebody in an emergency situation where they don't have any more insulin. The $99 programs take time to apply for. They take time for you to get the cards. They take time for you to get to the pharmacy. That's multiple steps in somebody who has literally hours left to live. In a case of somebody in an emergency, we are literally talking about hours where we don't have the time to hear back from a pharmaceutical company that is not open beyond the hours of 9 a.m. to 8 p.m. 5 days a week. If I break my last vial of insulin or I run out of insulin or have some sort of emergency on Friday evening at 8:30, I'm dead by the time Lilly Cares is open again. I'm dead by the time Novo Nordisk is open again. We are talking about an emergency situation where I don't have 72 hours to wait until I can maybe get an answer and then another application process. I need to go to the pharmacy on Saturday to get my emergency fill. So I think we really need to realize that we're not talking about multiple days, multiple weeks that we have. We're talking about mere hours. Thank you.
For reminding us why we was here. It's about emergency insulin.
Yes, emergency insulin. Thank you.
So we have Representative Schultz.
Thank you, Chair Moran. I have a question for the pharma trade representative, if she could come down.
Hi, please reintroduce yourself for the record.
Madam Chairwoman. Who had the question?
Thank you, Chair Moran. So, yeah, thank you. I'm wondering if you know how many people in Minnesota use these programs to reduce the price of insulin?
I don't have that number of how many residents in Minnesota use the 3 programs.
So it sounds like what I've heard in the past is that it's pretty low. And so if these programs are so wonderful and it's easy to qualify and everyone's eligible, you would think that a lot of people would be on them. So if you could follow up and let us know how many people in Minnesota are actually using these programs. And I think the point of the last testifier was really important, is that, if they're in an emergency situation, these programs are not very helpful and they can be eliminated at any time. So, this is not the answer, is to have these programs set up by the manufacturers or the pharmaceutical companies, when it would be so much easier if they truly care about people and preventing deaths, that they would just set an affordable price for everybody. That just seems like such an easy solution when so many other countries regulate the prices. And when we have this failure in the pharmaceutical market, that is when we have a role of government to step in. Healthcare is so different than other goods or services. We're talking about a matter of life and death. And so I'm really disappointed that we haven't done anything to address this issue in the last 2 years, and I hope we can address it soon so we don't have to see any more deaths. And I'm really concerned because we've heard so many testifiers talk about being on their parents' insurance until they're 26 because of the Affordable Care Act, and if the court cases decide that it's revoked, they are going to not have coverage. They will be kicked off their parents' insurance, and we are going to see more people struggling to pay for their insulin. So we need to fix this as soon as possible.
Thank you, Ms. Lamberto.
Yes.
Lamberto.
Madam Madam Chair, Representative, I think your point is well taken. I will look into the numbers and get back if I with you in short order. I do want to mention that the programs are our patient assistant programs are national, and that's one benefit where this is an important program, and we would. I definitely know there's been a lot of hard work and dedication gone into it, but the national programs, if a resident of Minnesota is in another state, this would be more applicable. It's portable. And I do know that I would just urge the qualifications. I know we heard a number of stories, but there are qualifications that are pretty high for these 3 member companies that have offered programs. Many of them have emergency insulin available, but more can be done to educate about the awareness and the expansion of these programs, I'm sure. Also, there was a question earlier, if I may, about the accumulator adjustment programs. I know that here in the state of Minnesota that discounts and a lot of the manufacturer assistance is not counted toward a patient's out-of-pocket deductible, and that's something that is extremely important for patients to have that assistance, whether it's manufacturer assistance, coupons, et cetera, that go toward the out-of-pocket deductible. We've seen 4 states pass this legislation to date. It's an important feature, a good patient protection, so I would encourage the members to look at that as well. Thank you.
Thank you. Okay, so members, one moment, Representative. We have, it's 6:20. We have 4 individuals on the list. So this is going to be like the last call. If you'd like to get on the list to ask the questions, then we're going to cut it off. Okay. All right, so we have Representative Huot.
Thank you, Madam Chair. I just want to bring to the point, but I want the pharmacy person to come back up. To add to this, and in my own personal experience in ambulance and in ER, usually these patients are those ones that are high-end deductible patients. The Medicaid patients, it's usually if they're DKA and we're bringing them in, that's very rare. But these ones, it's going to cost them about $2,100 to get an ambulance ride. Madam Chair, to the testifier, real quickly, I heard from the pharmaceutical industry that they said that the pharmacists aren't really presenting these programs. Can you tell me, because you would be the one that has to say no to these patients when they come up and can't get what they need, emergency, whatever. Are you pushing these programs? Are you helping them? What are you doing? Because it sounds like you're not.
So please reintroduce yourself for the record, and then
Yeah, my name is Sarah Durr. We actually at the association meet with these programs on a fairly regular basis, so I'm learning more. I have only been in my role for 9 months, so I'm still learning more about what they're doing. But I know that at the pharmacies, we do everything we can, specifically at independent pharmacies, to help our patients find those things. Now, sometimes at the chain pharmacies, it's a little bit more challenging because they have more requirements that they need to meet, and they may not be able to take that time with the patient. So I think sometimes that's where we're seeing that challenge, is that they aren't able to take the time in some of the roles that they're in. But I know the independent pharmacists and a lot of those that are in smaller chains are taking the time to sit down, work through the program, help with the application when it is something that they qualify for.
Madam Chair, just quick follow-up. So is it a cumbersome program? Is it really easy to get into? I mean, when you have an emergency need like this, it would be something that I think, and I do believe that you're doing everything you can, but what's the program like? Is it, I mean, you could probably phone a friend back there too, but, so, are they cumbersome programs or?
I believe that in the last year or so, they have improved. I still think there's very challenging with emergency and specifically. The long-term programs are a little bit easier, but they do take longer for them to actually get the application completed. So it could take them weeks to actually know if they are qualified for that program for the long term. But emergency is a little bit more challenging.
Thank you, Madam Chair.
All right, thank you.
Madam Chair.
Okay, Representative Howard.
Madam Chair, Representative Huot, I just wanted to mention a couple quick things. One, the one piece of Alec's bill that we did pass last session as a body created a public website through the Board of Pharmacy to kind of capture the entirety of what sort of programs and assistance is available for folks. And I know that we get that out to pharmacists. And then the other point I'd make about this program is it's designed to work very well for pharmacists. So somebody will be able to fill out their application. It'll be, you'll have your prescription and your approval sheet that'll just have a few numbers on it that the pharmacist needs. Hand it to the pharmacist, and you can have that processed and get your insulin. It's designed specifically to be a program that works seamlessly to sort of address some of that issue.
Okay, Representative New.
Thank you, Madam Chair. Representative Howard, again, going back to some of the testifiers, I appreciate some of the things they've said, and I apologize, missing names. I apologize for getting your name. The $1,200 a month income not qualifying for programs is bonkers. That's crazy.
Gentili?
Thank you, Ms. Gentili. Like that's crazy. I mean, I think we would all agree that that's just beyond the pale. My question is, Representative Howard, have you worked with folks who have applied under the new programs who are still not qualifying with that kind of income level?
Representative Howard.
Madam Chair, Representative New, a couple things. We've asked for some Minnesota-specific data from the three manufacturers about some of these newer programs. And just today, we received a bit of Minnesota-specific data from Novo Nordisk as an example of how many Minnesotans have been served by these programs. And some of them changed back in October. I mean, again, this is part that's confusing for folks. But I've talked with and seen some evidence of some of them being able to get through, but just as many folks that are still having challenges. And I wish Nicole was here. Nicole Smith-Holt would gladly tell you about dozens and dozens of Minnesotans that have reached out to her individually since January 1st to say that they're in an immediate need of insulin. And Nicole is somebody who knows every which way of these programs and has become this amazing advocate to point people to solutions that exist. And what she's told me is that there hasn't been much let up from people reaching out to her facing a crisis of an emergency situation.
Representative New.
Thank you, Madam Chair. I guess, Ms. Gentili, I would ask of you, like I said, bonkers, an income of $1,200 a month. Have you applied recently under the current programs and continued to be denied?
Yes.
Ms. Gentili? Yes.
Thank you, Madam Chair. Yes, I have been. I have applied. I have been one of the people that have reached out to Nicole because I couldn't afford my insulin. I know of right now, there's tons of Minnesotans reaching out to a bunch of us advocates asking for insulin because they don't qualify either. We get, I don't know, 4 or 5 a week, people asking us to help them with insulin. I'm included in that because, like I said, $1,200 doesn't go very far in Minnesota.
Okay, Representative New.
Thank you, Madam Chair. And I guess, Representative Howard, I would ask, have you inquired then, have you inquired with the manufacturers on that kind of data? Clearly, something's going on here because all of the manufacturers are indicating that there are programs at 400% poverty level. So clearly $1,200, I mean, well below 400% of poverty level. So I'm wondering what the process has been on that denial and why that is still happening.
Ms. Gentili, can you walk us through some of that pieces why you cannot?
That would be great.
Well,
That would be really
he's
helpful,
got life
Ms. Gentili.
experience. I want to know what.
Madam Chair, Representative New, I don't want to speak for Ms. Gentili, but because she's on Medicare, that excludes her from much of the support through coupons. And as I understand how there is some level of support for folks on Medicare on these patient assistance programs, but as I understand, they require folks on Medicare basically to suspend the rest of their Medicare prescription drug coverage to be accessible for the free insulin. And so Ms. Gentile mentioned several other medications she's on. My guess is that might make it wholly unacceptable for her to go through the patient assistance program as someone who's on Medicare.
That is correct.
Okay. Okay. Representative Pinto.
Thank you, Madam Chair. This will be quick. I just was trying to do some math from the information we had based on Representative Schultz's questions. Kind of dangerous to quote to a health economist some health math, but I was trying to do it fast. And I just saw in the Sanofi document, they talk about having 70,000 patients in 2018 be supported. And I just did some math. If the proportion of residents of Minnesota matches the U.S., if you kind of use that proportion, that would mean that about 1,800 Minnesotans would be supported by through the Sanofi product. That's out of a state population of 5.6 million. And if you figure that, I think it said 9.4% of people in the population have diabetes, so it'd be close to 500,000. So 1,800 people being covered as opposed to 500,000 people with diabetes. So we'll get the information later, but at least the information we have in front of us is that these programs are really not doing much. Thank you.
Thank you for that.
And Chair Moran, may I respond to that? Thank you, Chair Moran. So two of the companies responded, and their number was combined was 500. So it's even lower than 1,800.
Okay, we got some final thoughts from Representative Howard.
Thank you, Madam Chair, members of the committee, for the discussion. And I, too, echo my thanks to folks that took the time to come here and testify. It's your stories and strength and courage that have pushed us forward and must continue to push us forward. We absolutely have a solution in front of us, and the time is now. And so I appreciate that we're moving quickly this session, and look forward to the next step. Thank you.
All right, thank you so much.
Madam Chair, I'd request a roll call.
Yes, Representative Morrison. Oh, a roll call. Okay. So no further discussion. A roll call has been requested. So the chair renews her motion that House File 3100 as amended be recommended for re-referral to the State and Government Finance Division. Okay, clerk, will you take the roll?
Chair Moran,
Aye.
Vice Chair Morrison,
Aye.
Representative Keel,
No.
Representative Albright,
No.
Representative Backer, Representative Bonner, Representative Edelson,
Yes.
Representative Fisher,
Yes.
Representative Freiberg,
Yes.
Representative Huot,
Yes.
Representative Liebling,
Yes.
Representative Mann, Representative New,
No.
Representative Pearson,
No.
Representative Pinto,
Yes.
Representative Robbins, Representative Schomacker,
No.
Representative Schultz.
Yes.
So there being 9 ayes and 6 nays, the motion prevails. House File 3100 as amended is recommended for re-referral to the State Government Finance Division. We are adjourned.